It's just that the draft 2 trial. So, I mean, the big thing for plate express is wires was the cost saving, which you've not got to a similar extent. Also, where we're really going with this, is it not we're really going that actually, it's what Sam alluded to, when you have a manipulation of a displaced radial fracture in A&E, you're restoring the radial carpal alignment every time. That's the thing, you're reducing it and you're holding it. Would we therefore not be better? You're actually going to have to have draft 3, aren't you? Which is taking the patient to theatre and doing it doesn't really matter. So actually it's A&E, close reduction versus the other 2 maybe. But actually where we're going with this is actually just making the deformity go away in A&E is all that matters.
No, I think you're right, and it's a really good point. I think, because if we'd said at the beginning of this, and draft aim and profit the first of the big multi-centre randomised trials, if we'd said to you guys, I want you to randomise between your favourite locking plate and doing nothing at all, who would have taken part in that study? I probably wouldn't, because I believe in the plates, that's what we set it up for. We just need to prove they were cost effective. But now we're changing that situation. But I still think, if you're including the group in particular, then there's something about getting it was, you should understand, but the same message, lateral view, get the lunate back over the top of the long axis of the rays. There's still got to be something about that. Now, within the limits of the what's acceptable reduction, do I believe that those radiographic parameters we all learnt about at school matter? Well, there's a paper out next month, I believe, in BJJ, which correlates radiological outcomes with objective functional outcomes with patient-reported outcomes. Just have a look at that.
Matt, can I ask just a simple, straightforward question? One of the problems that I've noticed over the years with the distal radial fractures, which is essentially what we're talking about, there was a paper that came out a few years ago, and I can't remember the names, that was talking about putting wrist fractures in neutral as opposed to the classical way we used to do it in ulnar deviation and flexion, which seems to make more sense to me as an old fart. But the type of plaster being put on surely is going to influence this massively, because if you put them in a neutral plaster, which is what was shown earlier on pretty well, when you've got a fracture, the mechanism which was radial deviation, it's going to fall off. If you put them in a proper plaster, it's going to hold. How do you get around that one?
Yeah, that's a really good point. So we did agonise about what is the intervention here. The problem is how do you, and this is always a problem when you're trying to assess the fidelity of the intervention. Was it delivered in the way it was intended to? Is it delivered properly? But how do you know whether a moulding cast has been applied properly? And you only find out week 3, 4 when it's fallen off. So we decided we couldn't do. So what we're going to do is we're going to look at the radiographic outcomes as a surrogate for fidelity of the intervention in moulding cast. To be honest though, there is an argument that actually a moulded plaster doesn't require the ulnar deviation and flexion, and actually you can mould in neutral, and that may affect the supination that Sam talked about as being important afterwards. That's speculation.
I think we should probably wind up there.
Thank you everyone.
Thank you.